of this pandemic on education at such outlets such as CBC Radio Canada, the Globe and Mail, Reddit AMA, and TVO. And third, we have Dr. Jacob Shelley, who is currently an assistant professor in the Faculty of Law and School of Health Studies here at Western. And Dr. Shelley's primary area of research is in healthcare law and policy and public law and policy. And he's generally interested in the issues that arise at the interface of law, health science, and ethics. And his work on marketing of consumable products to youth has even helped shape policies at the federal level, including at Health Canada and the Senate. And so we are super excited to have these researchers who can really provide these unique perspectives for us here today. And so to kind of start off then, I'd like to kind of offer some time for them to maybe share a little bit more about us on their main research focuses and whether they have had any research efforts related to the COVID pandemic. So maybe I'll give Prachi the first at this, and then followed by Jacob and then Dr. Severio.
Hi, hi TD, hi everyone. Thanks for having me here. I'm really excited to be speaking on this panel, primarily also because I'll learn a lot from Saverio and Jacob, I think, in terms of some of the broader issues. I've been working on the effect of the pandemic on global education since around February, end of February. And, you know, given that this has impacted the largest mass closure of schools globally, we've seen 1.5 billion, over 1.5 billion students from pre-primary all the way through university out of school and education. At its peak, that was almost more than 190 countries that had nationwide school closures. And we're looking at approximately 90% to 93% of all total learners who are enrolled who are out of school. This has never actually happened in modern history in terms of this shutdown on education services. And the issues that we're looking at here are aggravated effects, not just in terms of learning outcomes, which we know there will be, but there will also be aggravated effects on psychosocial and mental health. We know from previous school closures in Africa in response to Ebola that it also led to increased underage pregnancies, sexual abuse, violence, primarily against girls and young women. And then, of course, there are the broader economic impacts to disrupting education and the fact that an offshoot benefit of having mass regular education, primarily in the elementary levels, is to have childcare facilities. I mean, it's an offshoot benefit, right? So it frees up a large majority of the working population to be able to work. And so all of these are now being, firstly, costed in terms of finances, but I look at it more in terms of the right to education and what that means going forward. What are the government plans globally and here within Ontario in terms of resuming education to a sustainable level? And does that necessarily mean reopening schools? So right now there's quite a big public engagement effort going on with certain governments to try and see if reopening schools is a good strategy. Certain countries have started to do this, and certain countries have done this having controlled the virus pretty well in terms of, for example, Vietnam. And other countries have done this despite actually having pretty active cases and having a very active COVID transmission scenario. So we're seeing now policy sway on this, and my research is focusing on trying to actually give evidence-based policy recommendations, both globally and here domestically, in terms of how we can resume education with a crisis-sensitive planning mode, with regards to equity, and predicated, of course, on a comprehensive public health measures strategy.
Awesome, thank you. Maybe Jacob can go next.
Sure, thank you very much for having me. It's a pleasure to be here. While we're on the topic of education and the impacts of COVID, there are 4 children somewhere that way in my life, and I'm the solo parent here today, so I apologize if there's any interruptions from them. A lot of my research historically is, if we look at the rates of a disease in society, how can we think about the role of law in preventing in managing and treating those diseases. And I've often been fixated with issues around food and chronic diseases. But COVID kind of, as it did for all of us, crept into my life just by its existence. And there's not a lot of capacity in Canada in public health law. And as a virtue of that, I've kind of retooled some of my research program in the last few months to look more at the infectious disease side. But where it's related is the questions are the same. What is the role of law, and how can law be used to prevent disease and to promote well-being? And I'm fortunate to be part of a team here at Western. We call ourselves the HELP Lab, the Health, Ethics, Law, and Policy Lab. And one of my co-directors, Dr. Maxwell Smith, sits at the WHO's ethics table and the Ontario ethics table. And so we immediately realized that there was a need to look at how are we going to undo the scaling of the measures put in place, particularly restrictive measures. So we have a project that we've called Scaling Back that was fortunate to get Western Catalyst funding and a few other projects we put forward to other funding sources. But our primary question is how do we undo what we put into place? And we're seeing that in real time, both in Canada and elsewhere, where we went from no more than 500 people to no more than 50 to no more than 5. And now we're trying to undo those measures put into place and to think through how do we do this in a way that is both ethical and legal. And there's a lot of implications with some of the recommendations, even, basic things like wearing a mask, as we've seen, has caused some controversy, but there are reasons for this. And then how do we actually take into account the impact on vulnerable populations, and how do we disadvantage those that are already vulnerable in this type of environment? And so a lot of the research that I've been doing that's COVID specific is right now just gathering. To be honest, we're just trying to gather all of the policies that have been put into place at the provincial level, municipal levels, the federal level, to understand how they were put into place and how they were enforced, so that later we can do a better job of creating tools for being prepared in the future. But also to understand some of the nuances. For example, I'm not sure where everyone currently is located, but I imagine that at some point, individuals on this call decided, I want to go play basketball, and trying to figure out whether or not you would receive a fine in your jurisdiction for playing basketball was very, very difficult to do, because the information that's being provided to the public isn't always consistent and it isn't always clear. And that raises some real questions around the permissibility and the implications on rights, for example, that may arise if people don't know how their rights are being infringed or interfered with. So our project is kind of up and coming, but also I think some of the stuff that will emerge from the COVID-19 pandemic is a rethinking of how we approach chronic diseases as well, how we think about tools that are in place to respond to chronic diseases. And my favorite hobby horse is, again, the food system. And we are going to witness undoubtedly a massive shift in how our food system is structured in response to COVID-19, because we're not going to be able to rely on international trade with the same sort of consistency as we may once have. And so thinking forward about how do we actually use the lessons from COVID-19 to inform our chronic disease responses, and not to minimize the impact of COVID-19 on the population or the concern that arises, but far more people in Canada still die from tobacco-related diseases and diet-related diseases yearly than infectious diseases like COVID. And so perhaps we can use the law in better ways, knowing how we've responded to COVID. I'll leave it at that for now. There's lots of other things that are interesting, but I'm curious to know the questions you have for us.
Saverio, maybe you can go.
Yes, again, thank you for the invitation. So, well, I will just summarize some of the work we have done over the last really 4 months around COVID, stating that I'm not an infectious disease epidemiologist, so I just want to make that a statement first. So, a public health physician and most of my work is actually in the area of chronic disease, epidemiology, and prevention, similar to Jacob. But obviously, as an epidemiologist, I've been looking at these pandemic unfolding, and my focus has been on two different levels. So the first level is around international comparisons in terms of epidemiological indicators such as incidence and mortality from COVID-19 across different countries. Because obviously, we had in February a workshop with Eric Arts and a few other colleagues, perhaps some of them are also in the audience today, making a statement at that time that what was happening in Wuhan or Hubei province would have had a global impact. So obviously, so we have been looking at the epidemiological trends of the pandemic, as it affected Europe first, my home country, Italy, and then other Western European countries, and then it came to North America, and now is spread all over the world. And you can see that there are some consistent patterns in terms of these indicators talking about incidence and mortality. And one of the challenges we have in global health or even international health is to make comparisons across country with very different socio-demographic structures in terms of the population. So when we compare, mortality rates between high income, for example, low income countries, we also need to recognize some of these differences in the demographic structures of the country. And the other thing is the quite dramatic differences in terms of the public health approaches implemented by different countries. And we recently published a piece in the International Journal of Health Policy and Management titled "What Western Countries Can Learn from some Eastern Asian Countries." And we were emphasizing how countries like South Korea, Taiwan, Vietnam, Japan, and have responded in a very, if you like, timely fashion in terms of community public health approaches, with a 3T approach. So testing individuals in a timely fashion, treating, isolating them with a widespread contact tracing. And by doing that, those countries have been able really to curb the epidemic at a very early stage. And as a result, if you look at the mortality rates coming from those countries, obviously the toll in terms of death has been quite limited. Also because, by the way, the demographics of some of those countries. On the other hand, Western countries have been a bit slow in terms of implementing public health approaches because most of our healthcare system are very much hospital-centered and they are very much designed for chronic disease management. And so these, I think, pandemic has flagged some of the intrinsic vulnerabilities of healthcare systems across many Western countries in terms especially of epidemiological surveillance and community-based public health approaches to curb the epidemic in the community in the first place. Because we need to remember that epidemics outbreaks should not be handled in hospital settings primarily, but especially in community settings. Unfortunately, in many Western countries, we have seen how the pressure on hospital settings has been dramatic because of the large influx of patients, especially those older ages, so with the chronic comorbidities. So this has been quite a consistent pattern across many Western countries, with some exceptions, and we can talk about that. The other piece of work we have done more local level with the people from Department of Geography, and this was one of the Western Catalyst grants we received, is to really try to set up an epidemiological surveillance system at the local level. So we're talking about our local community, able to capture new cases in a very timely fashion, and trying to also look at mobility patterns of those cases so that we can, in a sense, provide a public health unit with a tool which can be used also for future pandemics or future outbreaks, but potentially can also be used for chronic disease surveillance. And because obviously there will be life beyond COVID, and also in terms of investments, we also need to look at research which may have a wider impact beyond the current pandemic. So I will stop here for now.
Awesome. Thank you, everyone, for kind of giving us a little bit of more insight into your expertise and your perspectives on this pandemic. So before we kind of jump into our discussion topics, I just want to remind the attendees that if you guys have any questions that you guys want to ask the panelists, you guys have kind of two options. So we'll be having kind of a dedicated question period at the end where you're welcome to unmute yourself and ask the questions as we come. So you can like raise your hand at the end and we can pick you to ask a question. Or if you think of it during the session and want to hold on to it, you can actually comment it in the chat below and we'll collect all the questions there. And then I can kind of ask the panelists questions at the end for some of those questions. So those two options, just keep that in mind. Okay, awesome. So we're going to jump into some of our discussion topics then. So Saverio, I'm actually going to continue with you because you kind of hit on something that I really wanted to ask about, which was kind of learning these very important lessons from our international countries, so such as Korea or China, who have really treated this pandemic in somewhat of a different way than we have. So I was wondering if you could kind of elaborate a bit more on maybe some of the specific lessons that we could maybe learn from them in terms of handling the COVID-19 pandemic, both in terms of good things that they've done or bad things that we shouldn't do that they did. So can you maybe elaborate on a couple of specific examples that you might have?
Yeah, so basically, continuing on what I was saying before, obviously some of these Asian countries, to some degree, I will extend also to some of the sub-Saharan African countries, and I can comment on that also later on. But talking about Asian countries, those countries in general have a much stronger public health infrastructure, and most often those infrastructure actually have a kind of a centralized system. And also because, to be honest, they are used to deal with outbreaks or with pandemics in a kind of, or epidemics in a kind of a regular fashion. So obviously, going back to the comparison with the Western countries, we have not really dealt with such a pandemic, for many years. Although in Canada, obviously, we dealt with the first SARS, which had some common challenges, but was also very different virus, also in terms of the impact that pandemic or epidemic had on our community. So, generally speaking, I can say that, and obviously it will not be appropriate to compare or to put those countries, Asian countries, in the same group in terms of, because there are dramatic different. I did not mention China in my first presentation, because China actually, or at least the Wuhan Hubei province, they implemented a very drastic. They had to implement a very drastic measure, like a draconian measure, like a lockdown, which in a sense inspired also other European countries. I'm talking in particular about Italy, which basically followed that kind of Chinese model with a national lockdown itself. Although perhaps we can discuss that in Italy the lockdown was delayed. And also we now have evidence that the community spread of that virus was already present, perhaps months before we discovered the first cases, at least in Western Europe. Perhaps there is evidence now suggesting that some cases may have been already there in December. So obviously, what we saw then in February was if you like, the tip of the iceberg. And so we saw the most severe cases of an infection which was already widely spread in the community, which basically prevented Italy and other Western European countries from implementing that kind of community public health response of contact tracing, where the infection, unfortunately, was already widespread in the community. And talking about my own my own country, is paradoxical that the region which really paid the highest toll, Lombardy region, northern Italy, which is also one of the wealthiest regions in Europe, considered to have one of the best healthcare systems and the best hospital systems. However, that region really failed in the capacity to respond again from a community or public health perspective. And so basically, the epidemic was dealt very much within hospital settings, and with the large numbers of people accessing ICU, and especially elderly people, but even a large number of elderly individuals who were affected in nursing homes and also in their households. And that really inflated the mortality toll of the pandemic within the Italian context. And then, as the pandemic unfolded across Europe, we saw countries like, and I'm not blaming, I'm not making political considerations here, but we had countries like England and then US which were a bit slow in really responding in a timely fashion. And in fact, they then paid a large toll in terms of death, despite the fact that, in a sense, they had a couple of weeks as compared to Italy or France, Spain, to, in a sense, implement a more timely response to the pandemic. On the other hand, you have countries like South Korea or Taiwan or Japan, where the public health infrastructure is centralized, and they were able to isolate those infected cases at the very early stage. And therefore, they avoided that widespread community transmission of the pandemic. And if you look at the mortality numbers in those countries, they tend to be much lower than many of the Western countries I mentioned before. So in terms of the lessons learned, I think there is, obviously I'm a public health physician, so I have my bias, but I think healthcare system need to allocate, resources to straighten our public health infrastructures, because this will not be the last pandemic, as we are all aware. And so we need to reinvest in public health capacity across Western countries as well. And I think by doing that, we can also help preventing and managing chronic disease, because Jacob was mentioning that there are lessons to be learned also in terms of chronic disease management, because our healthcare systems are very much based on hospital care, rightly so, because obviously we also deal with hospitalizations, but there is in general a lack of emphasis on prevention, if you like, community management of chronic disease across many Western countries. And for example, I will emphasize the primary role that primary care physician should play also in the prevention and management, not just of infectious disease, but I will say also of chronic disease, so that we can, in a sense, reduce the pressure on hospital settings. So perhaps will be also the time to rethink about our healthcare systems based also what we have learned from this pandemic. I think you are muted.
I was muted there. Thank you very much, Saverio, for that. That was really interesting insight, but I think also Prachi may also have some expertise in the global effects of this pandemic, especially maybe in terms of the educational opportunities and things like that. So I was wondering maybe if you can kind of extend that a little bit.
I mean, I think the three of us are actually coming at it from very similar angles, despite the fact that we're looking at very different issues. Part of the reason why the impact of this particular pandemic has been so severe on education, and I mean generally in society, but looking at it from education, is the fact that most countries and most systems have not, as a matter of course, instituted a very concerted system of crisis-sensitive planning. We just, particularly in G7 countries, but in most countries, that's just not part of how we develop our policies. That's usually not how we operate. And the pandemic has exposed these vulnerabilities en masse globally. So I started my career as a humanitarian aid worker during the conflict in the Balkans almost more than 20 years ago now. And the lessons that we can learn from emergency planning, from long-term planning with a view of having contingencies in social sectors are vast. But most countries have not done this. So what we see is rather blunt instruments of opening and closing. There are very few places, I think South Korea is one, Vietnam is another, that introduced more nuanced initiatives in terms of how we can deal with some of the social consequences of this pandemic by instituting public health measures early and in a comprehensive manner. So given that the crises we're seeing are a result of a disease, the health measures that are instituted really do dictate a lot of what we've seen. Is that it's had a domino effect on the way that countries are then able to manage their other public services and social services. In education, what we're seeing is that countries that have lower income countries and countries that are considered quote unquote fragile have, as a matter of course, because they're required to by multilateral organizations and institutions that are actually that sit above their own governments. They're required to do that for aid. They're required to do that for assistance. They're required to do that for a number of other mainly macroeconomic policy measures. As a result, they are required to have much more cross-sectoral planning. They are, in a way, accountable. And I'm not saying there are lots of issues with multilateralism and accountability at this level in terms of where, global power positions of different economies. So I'm not saying that this is, a great thing, but the offshoot of that has been that these countries have been able to look at their systems in a more of an integrated manner, much more so than the two famous cases that we're looking at right now, which is the US and the UK. And I would actually include Canada on that in terms of being quite insular and being quite quite discreet in terms of how it plans. So we've been trying over the last couple of months, the last few, actually since February, to mobilize some kind of action here in Ontario in terms of having a real plan of action for education. We saw that in the first month, in March, when school closures were announced, the government made 3 subsequent announcements within a matter of 4 weeks. In terms of what it was going to, in terms of the school closures in Ontario. All of this leads to confusion. We don't see long-term planning. There's very little indication right now in terms of how things are going to evolve in September. And my kind of personal view on this, and this is looking at some of the more comprehensive measures that are being taken in some of the East Asian countries, is that I think if we're going to move towards a more nuanced, a more sophisticated strategy, that it should be one that is localized, so that we look, rather than blunt opening and closing of businesses, of schools, of every kind of social institution that you can think of, it should be more of a nuanced indication, community-based indications, community-based needs assessments that need to be tied very strongly to public health 3T measures. And until governments do that, it's very hard for us. It is a game of roulette. Because what will happen is that most likely, if they do not institute this, there will be another blunt mechanism of reopening, in this case, reopening all schools. And then we'll just hope that those school communities don't see school-based infections. And then when they do see those school-based infections, those particular communities or those schools will have to close again. So this is very volatile. It's interrupted. That has happened in Quebec. We've seen that already happening in Quebec. It's happened in France. It's happened in places where there really has not been a very concerted, community level, nuanced, fine-grained understanding of transmission patterns. And until we actually do that, it's very hard to do anything other than institute blunt mechanisms. And that's not very sustainable for the long run.
Excellent. Thank you so much, Prachi, for giving us kind of that perspective. So next kind of question I really want to come to Jacob with, and we're kind of still staying on this kind of main question of socioeconomic factors and things like that. So one of the main things this pandemic has really highlighted is the need for kind of fair allocation of various resources, that be medical resources such as ventilators for those who are affected, and dividing that between patients, healthcare workers, etc. So I was wondering, for these resources, could you kind of help us understand a little bit better how these decisions are made in Canada regards to kind of allocation of these resources, but also maybe if you're able to compare it against more global policies and how they do it in other countries, and whether there's pros and cons between ours and theirs.
If I could answer this question well, I think I'd be a rich man. I think I could help a lot of countries and places figure this out. The reality is that I think before we even talk about the allocation of resources during COVID, it's really important to recognize we already have a very inequitable allocation of resources in healthcare and in public health, period. And that is part of what we're actually seeing. One of the stories of COVID that is not always being covered in places like Canada is the disparate effect of COVID on certain populations, racialized communities, communities with lower socioeconomic status, nursing care homes as a one example. But that's not just because they're a population that is older, it's also the system in place that doesn't have proper checks and balances. And so we already have an inequitable allocation of resources that is being exacerbated by this disease and being exposed. For some people, I think this is the first time they've really had to think about what does it look like in a world of scarcity for them, because it might be their first exposure to scarcity. So an example of that would be housing precariousness. There are many families in Canada that already live with housing precariousness that are now on the precipice of that because of lost jobs, unemployment, lost investments, etc. And so when we talk about resource allocation, it's important to start with there's already inequities that exist that make it harder then to correct midstream for places that are already lacking proper support. I think the theme that's already coming out is the lack of a proper infrastructure in place to manage or to respond to these kinds of issues as they arise. When it comes to the actual allocation of healthcare resources in Canada, we don't have a system because we have 14 healthcare systems in Canada. Every province has their own, and there's a federal system as well, and they all make decisions in different ways. And often these decisions are made in somewhat of a closed fashion where there isn't public accountability. And I think that might be part of what we need to address going forward. I know that when we talk about allocation of resources specific to COVID, it becomes an issue of communication and of community in my mind. And the example would be that we know that there are hospitals that were sitting on, swaths of PPE that didn't have outbreaks, but were apprehensive to share that PPE lest they one day faced an outbreak. Or similarly, the access to ventilators or other medications even. And so we have a system already that we lack proper communication between not only governments and jurisdictions, but between actors within the system. And so the resource allocation part of it is sometimes not even about scarcity, it's about coordination. And I can't really speak, I'm reticent to speak to the global situation. I'm not super familiar with all the global decision making. But one thing that I think we have seen consistently is that globally, one of the ways that we can prevent this kind of pandemic potentially in the future is a concerted effort where we share resources as international communities rather than try to hoard resources. And we've seen some of the fallout of that from the US in some respects with the 3M story that we're all familiar with feels like years ago, but it was just maybe a month ago now. We've seen the same sort of discussion playing out with the sharing of resources where some countries have been sharing resources with countries that are facing outbreaks that have a lack of resources. What I think is maybe a more challenging question and we've not yet had to deal with in Canada is what happens if it gets far worse. We haven't been overrun as of yet, and we haven't had to make hard decisions as of yet. And there is a triage protocol that's being developed in Ontario that's been getting a lot of heat for how it's allocating resources, because at some point, were there to be a serious outbreak or a hotspot and hospitals were overrun, we simply don't have enough resources to help everyone. And it's not something we like to talk about, but perhaps we can't help everyone and shouldn't. And that's a terrible way to think through problems. No one wants to have those conversations, but as part of what the triage protocol is trying to establish in Ontario is what happens when we reach a certain threshold where we're at 200% capacity, then what? And the reality is that there's no satisfactory answer to these questions, because at some point there will be groups of people that will be left out of receiving care. And for those that are in the healthcare profession, this will seem like a violation of their sacred oath to do no harm and to benefit patients. For governments, there's no winning in this respect for how they make decisions. And for patients that are affected and their families, of course, it's going to be devastating if it's your family member that doesn't receive resources. And I think that what we might need to do, and this is stepping back a little bit and maybe going to some of the other comments about being prepared, is we need to have these conversations prior to an outbreak, right? We need to have conversations about how to manage and provide proper resourcing prior. But there's the comment was made by Prachi a minute ago about like we can look to the other examples and learn from this. Well, there's been a paper written about all the lessons that we talked about post-SARS, post-H1N1, post-Ebola, all the things that we could have learned and none of us did internationally. So, or few of us were prepared internationally to deal with this. So it's more than simply allocation of resources, actually learning from this example this time around that we need to be prepared, because as Sylvia mentioned, like it's inevitable. Those of us that work in public health, this was inevitable. This is not a surprise. We just didn't know when or what, but a pandemic was coming. And I think given the global population and the interconnectedness of us, that it's probably going to be more frequent than we'd like to think. And I think we can manage them better with conversations in advance, because the next one perhaps will be a respiratory illness, perhaps not. And we're going to have to discuss resources that are yet unknown. And I think the best way to address that would be to try to get, to the extent possible, people on an equitable starting point, where those that live in rural or northern communities or indigenous communities or low SES communities have access to resources, period. And I'm not just talking about healthcare resources in this context. If we're jumping back to education, and I think the question, I just kind of saw the text, what about those that can't afford to be online to learn? Like, we have a serious deficit. I think my video might be lagging, and I live in a small town just outside of Kitchener. I'm really close to a city center and I can't get decent internet here. I can't imagine living in rural Ontario or rural Canada. How do we actually provide resources in an equitable fashion is something that we need to talk about, and we need to hold our politicians to account for. And healthcare resources are a big part of that, but I think preventative resources are a much bigger part for future pandemics.
Yeah, those are all great points, Jacob. And I think some of the most prudent points you made was really that we should be having these conversations now before we reach the point where we need to really use the actions that these conversations are generating. And I think that's really important. So I'd love to still stay on this conversation of kind of social economic status, and really how this pandemic has really highlighted the problems and the gap between socioeconomic statuses, both in Canada and globally. So I'd love to stay on this conversation a little bit longer. So I'll jump to Prachi, but then also give Severio like a chance to kind of comment on this as well. So I know, Prachi, you really pioneered research into educational practices like low-fee private schooling in less developed countries. And so I really wanted to kind of hear your input on how this kind of varied socioeconomic status gaps really affects education, both in Canada and on an international scale. And then I know that Severio also has some expertise in doing work like in sub-Saharan Africa. So I'd love to hear your insight on how these factors kind of contribute to kind of the spread and the controlling of this pandemic overall. So I'll let Prachi have the floor first.
And there's also a related question online, I think, that Olivia asked about the parents who can't help to teach, and and the inequities in terms of having access to resources generally. Yeah, I mean, I think as all of us have noted, the pandemic exasperates existing inequities, and we see that in all of our social sectors. In education, I think the first kind of knee-jerk reaction in most high-income countries, and particularly here in Ontario, in Canada generally, but in most high-income countries, was twofold. First, it was, oh, we didn't realize that we're going to have to do something about this in terms of education. Well, okay, let's close the schools because there's a transmission issue that we don't actually know yet, right? We don't really know the transmission mechanisms. Let's just close the schools. And so most 190 countries, most of them did this. The second thing was, now schools are closed. Okay, this isn't going to be it's not going to just be a 2-week thing as we initially thought. I don't know why people were not paying attention to the actual evidence and literature coming out from the health sector. It behooves me anyway. So, okay, we can't do it for 2 weeks. The kids are at home. What do we do? This is literally, I mean, these are the kinds of conversations that I've actually heard, right? So I'm not paraphrasing. Some of this really is just people not really having a clue. What do we do? Okay, yeah, let's do everything online because that's what we do. Let's just move everything online. And that has so many assumptions in terms of access to resources, in terms of abilities, in terms of home, and whether or not home actually is the safest place for some of us in society. It might not be the safest place. It isn't always the safest place. We know domestic violence and violence against women and children has increased and will increase when there are prolonged periods in certain circumstances for people to be there. And so a lot of this was driven, especially in high-income countries, by assumptions on access, assumptions that we in high-income countries here in Canada have a relatively good deal on most things, and we're all pretty equal, and we have equitable access. These are assumptions. They're not particularly, they don't actually pan out when you look at the data. So the data on, just if we want to take the example of online learning, was that roughly 100,000 learners here in Ontario, 100,000 learners here in Ontario did not have broadband high-speed access. Okay, that's a lot of people. And yet the system just went fully online. Practically overnight, all of us here at Western knew that we had about 3 days, I think it was, to kind of convert the last of our few remaining classes. And universities are a little bit better equipped to deal with, I'm not saying it's great, but they're a little bit better equipped to deal because we do have things like OWL, we do have more of an online infrastructure. Elementary and secondary schools, that is not how we deliver education. That's not the mode. And so you can imagine the confusion and the lack of preparedness. But what was also somewhat infuriating, and I'm being quite candid here, I'm being less measured, I think, than I am when I make more of a public statement. But what was infuriating for me was the fact that there have been for years, and continue to be, models of delivering education remotely and at distance that do not solely rely on the knee-jerk reaction that we saw. There are other ways of delivering this which might actually be more equitable in terms of having print-based instruction, using SMS, using our televisions. We have CBC, which is a public broadcaster. We have TVO, which is a public broadcaster. We have access to university radio frequencies. We have access to print-based materials. We have Canada Post. We have a courier system. We have resources in terms of funding that are not used in the education system. And none of that was actually put into place. And to me, that was just partly, I think, a result of woeful, inadequate planning. I mean, just woeful planning in terms of thinking of a real framework. What is a framework, an alternative framework, but also a little bit of arrogance on the part of high-income countries in terms of wanting to open themselves up to learning those lessons. And I say this as somebody who has participated in very high-level fora, who is doing that currently. I'm leading a policy brief for the G20 Summit on education and emergencies. And as a result of this pandemic, And so I'm not saying this lightly. There is a certain level of reticence, and I don't know how else to put it, just global reticence on thinking of a solution that will benefit the most disadvantaged in our societies globally. And I think we see that right now over the last month in terms of what is happening globally for seeking movements for social justice and equity. We see that here in Canada, we've seen that in the US, we've seen that globally. But in terms of how we deal with that in education, we've seen an announcement that we're going to be going back to some kind of normal schooling and education provision in the fall. I have yet to know of any concerted task force in education that looks at this from a multidisciplinary perspective. People coming at it, people like Saverio, people coming at it from Jacob's perspective, people coming at it from this true multidisciplinary perspective and knowledge need to be on a task force. We need to create something like that. I have yet to see that. I have yet to see a reframed curriculum. I've yet to see any real policy action on how that is going to look in a situation of volatility. When September comes, we are unlikely to have a vaccine. We are unlikely to have a huge new miracle treatment. Maybe we will, I don't know, maybe we will. But it still requires, even if we do, it requires a nuanced perspective and a contingency plan. What happens when we reopen our societies and we have to close them again in certain communities, or are we going to have to close them again en masse? And when we do that, it does disproportionately affect those of us who are the most disadvantaged in societies. So aside from, what we have seen, of course, is an expanded social security system for the time being, which is temporary, which we've had to put in billions of dollars, which I think was necessary at the time. But there are other ways of dealing with this. South Korea did very minimal kind of lockdowns, kept schools closed throughout the entire time, but did minimal economic lockdowns and hasn't suffered the kind of economic consequences that we're seeing right now. Vietnam very quickly instituted public health measures and kept their schools closed, reopened them, and hasn't had to close them again. Right? This is real success, and we're not learning from that.
I was just going to jump in.
Really
sorry,
yep, okay. Sorry, go ahead, Jacob. Go ahead.
Just because you asked me about resource allocation earlier, and one of the things that we need to also bear in mind that we don't know if we're going to have a vaccine by fall, but even if we did, one of the things that we have to do that we've never really done is this is a global decision about allocation. Most of our decisions about allocations with medicines, with vaccines, we're good at doing that or relatively good at doing that within a particular domestic context. Who do we prioritize? How do we prioritize them? We've never had to do this at a global scale where we'll have different political ideologies, different systems of government, all vying to get access to what will be at that point a limited and valuable resource. And so it goes beyond, even if we have a vaccine in September, we're a long ways away from having a vaccine everywhere and having it meaningfully in a way to, and I don't think September is realistic anyways, but even if it were, it's still not going to answer a lot of these resource allocation questions. And so I think the point that's being made is we can make plans that are well suited to dealing with this pandemic situation. And I agree, we've seen reactions. We're not seeing planning. We're seeing a lot of reactions to things.
No, and in my mind, it should be like a 2-year contingency planning, at least for education. It needs to be a 2-year approach, and it needs to really be integrated with exactly the kinds of issues that you're both bringing up.
Yeah, so I think my colleagues have addressed, most of the important issues. As Prechi was saying, I mean, this pandemic has revealed many vulnerabilities, lack of intersectoral partnerships, because, public health response is not just about health, it's also about education, it's also about economy. So, there are many other sectors which also should be involved in decision making. So that's one point. The lack of international partnerships, even in terms of, shared responses, in terms of, sharing of knowledge, for public health approaches, sharing of transparent data. And people tend to blame WHO, but WHO has a huge role with very limited resources. So, and I talk especially from, for example, from an European perspective, that I've been fairly disappointed by the lack of a coordinated response, even within Europe. And so this goes back to, the issues I think both Jacob and Prashi were emphasized about lack of international partnerships. And, the other issue that you were asking, TD, about, health inequities. Obviously, the pandemic has widened health inequities at different levels, including, in terms of educational outcomes, because I think one of Olivia was asking about, what happens to kids from, disadvantaged populations. And I think we recently worked on a piece with Mike Silverman on the ethics of school closures, because school closures, was driven by draconian measure of public health at a time where there was no evidence, talking about, 3 or 4 months ago, about the potential transmission of the infection within school settings. I think after, a couple of months, we now have more evidence on the relatively limited role that, school settings will have in spreading the transmission, because kids seems to be very little affected by these virus. On the other hand, they will have long-term consequences, having been 3 or 4 months in lockdown situations. And the last comment I made, because you were asking me about, sub-Saharan African countries or other low resource settings. Again, obviously, the Western model, if we can call Western model, dealing with the pandemic, which is hospital care, ICU capacity, ventilators, will not be applicable to any of those countries, because they have very limited capacity in terms of, hospital care. And there, again, in those countries, the crucial role of public health is even more crucial, if you like, because they will need to curb the epidemic at the community level, because they will not be able really to cope with the needs of a large number of hospitalizations and so forth. So in those countries, I think there are lessons that we can learn, because they are used to deal with infectious disease. Infectious disease surveillance is a huge part of healthcare systems in many of the African countries. We have completely, from a Western country perspective, we have completely or largely reduced investments in infectious disease surveillance and in public health in most of our Western countries. So I think that's one of the important lessons that we need to address as we move forward, and also focusing on emergency preparedness as compared to just being reactive and wait for the new virus to affect our countries.
Amazing. That's really awesome. So I'm just looking at the time. I'm going to ask one more kind of question topic, and then I'm going to open it up for some audience to kind of ask their questions here. So something really interesting. I guess I'll come to Jacob for this first, but I'm interested to hear all of your opinions on this matter. And so it's really about how this response to the pandemic has really been politicized, and how a blunt or a nuanced strategy can be successful when there's a lot of misinformation, disinformation, and willful ignorance against the public health. So how can these strategies really be implemented properly with that?
Yeah, we've created this system now that is dangerous, because we've created a system in which we do not trust experts, that we politicize everything, and that we put a high emphasis on individual liberties over community safety. And I think the disinformation is, I think it is a bit of a big problem. It's a bit of the issue here, but I think it's beyond disinformation. I'm not sure it's that people find the wrong information. I just don't think some people care anymore. And I think this is another conversation we need to have, where we have such deeply entrenched ideological perspectives that there's no amount of information or evidence that will ever be effective in convincing people otherwise. And unfortunately, the word draconian was used. We might be on the precipice of real draconian laws in response to COVID-19 as a way to halt its transmission. We will see potential infringements of rights and use of our private information as a way for contact tracing, etc. And there are reasons to be concerned, but I think at the heart of public health it's about what we as the people collectively can do to ensure the health of the population. And I think that's where we need to start emphasizing, is that this is a community collective response, that there's not a whole lot an individual can do. Like wearing a mask is a good strategy to protect yourself and protect others, but it's only part of a bigger strategy. So I think we have created an environment where, I think it comes back to the education aspect. We need to start educating people early on about public health. I think public health has taken a backseat to healthcare and illness care for far too long. And we need to really emphasize the collective responses. I know we have a lot of time, so I'll end there just to let others talk.
Yeah, feel free to jump in if you guys have something to speak on that as well, either Prachi or Saverio.
I think one of the issues around disinformation, there have been quite a few public campaigns that have started and some research hubs that have started around this. The role of our technologies in driving that disinformation, social media and driving that disinformation is crucial. But in terms of how to gain trust, part of the disinformation or this willful ignorance, I think, might also come from this idea that there's been a lagging response and almost a non-response by many governments in terms of how to deal with this. What people want to see is clear, decisive action. And it would be really interesting. I mean, this is not something that I do, but it would be really interesting to see what political scientists are doing in terms of gauging public trust in countries like New Zealand, for example, where they saw clear, decisive measures, in countries like Germany, where they saw clear, decisive measures, and Denmark and South Korea and Vietnam. Like there are countries that instituted clear, decisive action, even in the face of incomplete information. And I think that is where governments and citizens can demand, citizens can demand their governments to have clear, decisive action. And governments that kind of flip-flopped like ours did, I don't blame people for feeling that can they trust anything that comes out of an official source, because they don't see this as part of an integrated plan which is well communicated. If we start there, perhaps there's a chance. But when you see the kinds of ad hoc responses that don't seem to really be underpinning any broad framework, I think it's really hard then in terms of how we engender that trust.
If I can just add to what my colleagues said, I think obviously the countries that have done well in terms of communication, and Prachi was mentioning a few, are those where there has been consistency in terms of the messages from both the political leaders and the so-called experts, public health experts, virologists, or epidemiologists, and so on. In other countries, where the voices have been extremely inconsistent and confusing, that also plays a major role in the kind and efficiency of public care response. Because obviously communication, as Jacob and those who work in public health, is a huge piece of public care responses. How you communicate to the lay audience, and how the lay audience will embrace those public health recommendations. From my global perspective, and perhaps because I'm too positive about Canada, but I do believe that Canada has done a fairly decent job, at least in terms of consistency of the messages, to the extent that I can see, comparing also with other high-income countries, especially in Western Europe. But the communication piece is extremely important in terms of public health. responses. So I think, this is another lessons that we need to learn, for the way forward in terms of, how important, even from a political leadership perspective, is the kind of recommendations you make, as Parachi was saying. So even in a context where there is lack of information, because obviously there were many unknowns 3 or 4 months ago, but you need to see that kind of, consistent transparency in the communication flow. And some countries have done a much better job than others.
Mhm. That makes a lot of sense. So we have a couple minutes left that we can kind of cut into the break a little bit. So that's okay, because I feel like our discussion is really meaningful right now. So if anyone has any burning questions, once again, please just like raise your hand, or even just easier, just comment it in the chat. Once again, we have a question from Olivia here. And I'll just ask it to anyone who is willing to really answer the question here. And it's the idea of a global government, or even the World Health Organization. Is that enough to really shape the responses of countries as a whole, or individuals, to situations like this? Can they kind of play a bigger role in kind of forming these global agreements in terms of how to act in these kind of times?
Well, Jacob, may I, obviously in the ideal world, you would like to see, a role played by organizations like WHO in terms of, driving a kind of synchronized, coordinated response across different countries. Realistically, at the end, WHO cannot do that much, because there is always the independent decision making, and also the political leaderships, will always claim their independence decision making process. But in context of a pandemic, I do believe that you need to have a coordinated response globally. How we do that? Well, I think WHO can play a role, but obviously it's also a matter of resources. As I mentioned before, organizations as WHO, do survive with very limited resources. So I'm not sure if, that is really in the capacity of WHO to implement, that kind of coordinated response, as it should be in the instance of a pandemic.
I think there's also a challenge with global governments, because we don't have a global approach to governing, or global legal systems. And so I think we can improve and support institutions like the WHO. But unfortunately, with some of the current leadership in the world, that might prove to be difficult. But I think that we will, one of the lessons that we may take away from this all, the end of whenever this kind of starts to dissipate in a year or two, we will be able to look at countries, and some have come up already, Vietnam, South Korea, that have managed it better than others, and or managed one aspect of it better than perhaps others, and take lessons. And I think the challenge, though, will be that in all of these measures, one of the challenges of public health is that we end up having great success in public health when no one knows about it, because when it's working and working well, nobody knows that it's working. And so it's only when it's not working that we actually need to do something. And so that makes it really hard to get political and public buy-in, because no one cares about, like, we love to drink our water, but we don't think about the fact that there's a whole system in place to keep our water safe and clean until it's not. And then we have to react. And so I think it's part of that education piece as well. And hopefully that will become part of our global governance, the
So
efforts, promotion.
I need to comment on this. It's David Spence. Can you hear me? Saverio said that Canada did a great job. That's really not true at all.
Relative statement, not absolute statement.
Australia called in the army on March 23rd to enforce quarantine on people entering the country. They had virtually no deaths, very few cases. We waited way too long. We had people packed into immigration halls. It was ridiculous. We waited way too long to say that people should wear masks. We didn't tell them they had to wear masks. Canada did a terrible job.
I was
Saverio,
making,
you're
you know, I was making, I agree with David about, you know, obviously we have countries like Australia or even New Zealand, which did a much better job than Canada itself. I was talking about the communication piece. I was not talking about the efficiency of the public response, because I do agree with David that also Canada was a bit slow in the kind of public response. And perhaps that has been driven by economic considerations. Again, public health, we try to make the best recommendations, but then there is always a trade-off. And for Canada was, you know, keeping or not that border with US, because that has been my concern number one from, you know, the start of the, and, you know, I remember talking myself to some of my colleagues when this was unfolding dramatically in Italy. To be honest, you know, just confidentially, some of the people, even physicians, say, "Oh, but you know, this will not hit Canada." Well, it will hit Canada because this is a global issue, as we already knew, you know, from what we were seeing in China. Because as Jacob said, you know, in interconnected world, how can you think that, you know, what's happening in China will not have implications everywhere in the world? So that obviously is an assumption from people that do not really understand what global health means in current society. So my evaluation of Canada was around communication, and it was a relative comparison with, for example, especially some Western European countries where the message, you know, I'm talking especially about UK, I can talk also about US. The messages between, you know, leaders and the public health experts have not been necessarily always consistent. So that was, I was not talking necessarily about the efficiency or efficacy or the timing of the response in Canada as compared with Australia or New Zealand or other countries.
I think you raise a very good point, Saverio, and in relation to David, your comment. I've been following the UK scenario quite closely because I'm also British, so I have a personal connection there. But the one thing that I do see that's different between Canada and the UK in terms of, I mean, the response was ridiculous at the beginning. And in fact, I did some policy tracing in terms of this idea of herd immunity. And that first paper that came out, the chief public health officer thought that was a farce. I mean, they actually thought that that model was just there as a farcical statement to say, you know, that no way would that be taken seriously. But the one difference that I have seen is that there are a number of independent commissions that have been set up that are actively trying to, and have been successful in a certain extent, much too late perhaps, but have been successful and to actually change, firstly, public opinion, but also to change government response. I don't see that level of citizens engagement or expert consultation, independent commissions here in Canada. I just don't. And that has something to do with the way that we govern. It has something to do with a general lack of political engagement within our citizenry. Other than if you're from Quebec, and I am from Quebec, so I know that that's, we're always engaged because we have to be, no matter what side of whichever issue you're on. But in terms of real engagement with these kinds of processes, I haven't seen that. I mean, there was an independent commission that was set up called the SAGE Expert Committee on Education. And in the UK, they had decided that they were initially going to open schools in England on the 1st of June, and some did open. Wales said we are never going to open. We're not going to open then. Northern Ireland and Scotland said it would be sometime in August, maybe. And the commission came out and said that actually you should not be opening in June because it's very unsafe. The situation has not been quelled, and you should wait until September. That report got suppressed. It got suppressed, but it got picked up in the media. It got picked up by citizens. It got picked up by engagement groups, and as a result, now we have seen a change to that, to the idea of reopening schools before fall. We can argue whether or not that's a good, situation for the children in the UK, and I believe in Scotland the situation is much different than it is in England in terms of the transmission issue. But I just don't see that here. So it goes back to this whole, the bigger question that I think somebody, was it David Carter, I think, raised in a chat message about this question on disinformation and public engagement. How do we do that? How do we compel our governments to take decisive actions in the face of not having a functioning global governance system, and also where high-income countries are really not bound by the same global accountability structures that low-income countries are. We're just not accountable to anyone else. And so if we don't want to do something, we don't do it. And as a result, if we don't want to be prepared for a crisis, it doesn't matter because we're not really dependent on any aid money or any macroeconomic support from any other multilateral institution. We just do what we want. I don't know, like, I don't have an answer for that, but I do think it exposes, this exchange exposes the problems that we have with dealing with any kind of crisis. This time it happens to be a public health crisis. Tomorrow it can be something else. We don't really know.
Perfect. So we're going to ask one other question from the audience here, and this one is kind of about long-term care homes and how they've really struggled to take care of that very vulnerable population. And so I was wondering if you guys had some comments and perspectives on why that infrastructure has really failed these populations and how we could, change policies potentially to really improve that.
So obviously it failed people, but I think the infrastructure did actually what we would have anticipated it to do if we were to test it. It actually acted as it's expected when you have underfunded, under-resourced, under-managed, lack of accountability, lack of inspections or inspections that are coming with warnings. The system did exactly what it was supposed to do. It just was hoping that this would never arise, I think. So I don't think it's a failure. I think it did. I know that I'm being cheeky here, but one of the ways to respond to that better is we need to have in place a couple of things. One very basic thing is a system of accountability for those that run these institutions, for the government's oversight of these institutions, those other institutions. It's not a surprise to anyone that's in nursing or worked in long-term care homes that this happened, because they know that there's already rampant problems with the lack of personnel. They don't even meet the criteria that was expected, which was already too low. We've seen this in the Elizabeth Wettlauer example of the euthanasia, the murder of patients because of lack of oversight and accountability. So we have a system that's just been gutted, essentially, from having any sort of oversight and any sort of accountability. And without accountability, I think this will happen again. No matter how much people are paid, there needs to be accountability for these institutions. And then beyond that, I think we need to rethink kind of how we look at long-term care and what it means to be in long-term care. We have a very poor community system in place. There are other models other than just putting individuals into a home and then leaving them there. And I think that's a bigger societal problem, but I think at a minimum we can have and should have measures in place, and we'll see what Doug Ford's government does, because he's part of the reason why there was a lack of accountability, and we need to hold that government to account for that. The problem predates Doug Ford, of course, but he didn't help it by any means.
Yeah, I think that's a great answer, really, and really gives us a lot of insight. And so kind of just to wrap up, this hour has really shot by us really quickly. Like, it just flew by. So I just want to end off with one last question for all of you guys, and maybe you guys can provide one comment. And so just kind of out of curiosity, what if there is one, what is one kind of lasting social impact or social norm that we did prior to the pandemic that you think will not be done or be completely changed forever after this pandemic? If you guys can think of one. Anyone can go first, yeah.
Drinking from somebody else's glass, maybe. I don't know.
Drinking from someone else's glass, that's not going to happen anymore.
I think people will think 5 times before they do it.
I think we give many things for granted, as the possibility to travel all over the places, the possibility to have social gatherings at any time. Obviously, this pandemic has you know, revealed that, you know, most of those things are not necessarily you know, things that, you know, so I guess that some of our social lifestyles may be impacted in the long term, because obviously, you know, that's when I say Western European countries can learn also from Asian countries, because some of those social, if you like, habits are actually part of that culture. And I'm not sure if, you know, Western countries will be able to really embrace those changes. But I hope that, you know, some of those may happen, because, you know, I think there is a potential gain even in terms of, you know, public health. Yeah.
Mine might be not as popular, but for many years I've liked this idea out of Rome, where it's the Latin, I won't try, but this idea of bread and circuses, that if you can entertain and feed the population, you can get away with whatever you want. And I think that the lack of professional sports to distract us, the lack of entertainment to distract us, has made us kind of look around and go, there's a lot of inequities. There's a lot of things that are not okay with society. And I think of the Black Lives Matter movement right now. I think it needed to gain steam anyways, but there's a lot of people that are not distracted by other things. And I think we need to get rid of the distractions. And once we have addressed inequities, let's bring sport back. Sure, but I don't know that sport should be our priority. And right now it seems to be a headline daily. There's 2 headlines today about the MLB and NFL, and part of me goes, perhaps we need to step away from this kind of thing for a little bit and retool society.
Football started in the UK, and they had Black Lives Matter jerseys and NHS on the front, and fake crowd noises. And I'm not a football fan, but you wouldn't even know that it was the middle of a pandemic the way that it was being broadcast. But I do agree with you, Jacob. I think we are going to be a lot more in tune to some of these inequities. I think some people who probably escaped general societal inequities for most of their lives and most of their daily interactions and most of their institutional interactions, some way or another, perhaps the pandemic has affected them in some way, maybe not the same for everybody, but maybe that's opened their eyes up a little bit. And the social equity movements that we're seeing around race, combined with actually the inequitable impact of race on deaths, what we're seeing, which might be related. We don't think it's genetic, and there hasn't been studies yet on that, but we think certainly the way that certain communities and groups are positioned within societies and what that means. There's a report that came out in the UK called the BAME report that showed this. There's initial data coming out of Montreal. All of this is showing inequities. And I agree that I think it's going to be much harder for people to turn a blind eye to those things. And I think that's really positive.
Awesome. Thank you very much, everyone. So with that, I'm going to kind of wrap up this panel discussion today. I want to first please join me in thanking our panelists, Dr. Saverio Stranges, Dr. Jacob Shelley, and Dr. Prachi Srivastava, for kind of really joining us, taking time out of the day to really discuss some really important topics that are relevant to the time today. And so hopefully everyone can at least learn something from what we've discussed today. So just kind of wrap up then, of course, I encourage you to continue following the works of our panelists, because I'm sure they'll be doing a lot of great work in terms of this pandemic and all the things that we've talked about. And so there are some resources that the panelists have provided, some readings and things like that. So we're going to be posting those on our website afterwards on the same retreat page. So feel free to go there and check that out afterwards, as well as we have recorded this session. So we'll probably post that up also on our website for you to kind of look back and take away anything that you want. And so thank you once again for attending. I'm going to pass this back to Olivia to kind of just brief you on things that are going to be happening afterwards. Thank you very much.
Thank you. Thanks, everyone.
Great. Thank you. It was fantastic.
Thank you. Have a great weekend.
So I'm just going to share my screen again, so you all are now updated on the schedule and time, which means we will be moving into our afternoon oral presentations again in both Zoom Room A and Zoom Room B. Again, the ID link is up on the screen, but you can also go onto our website to directly access both of the links at your fruition between the different time slots. So those will start up at 2:15. with a little bit of breathing room, and then we'll move on to the 3-minute thesis in the later. And that will involve no question period. All questions are asked to be said